Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we have the conversations behind the content. I'm your host, Dr. Alyssa Watson, and this is part 2 of our special 2-part series on primary immune-mediated diseases in dogs. In our last episode, we tackled IMHA and ITP with Dr. John Thomason, and today he is back, and we are exploring 2 more conditions that you are also likely to see in practice, maybe not quite as likely as IMHA and ITP, but those are immune-mediated polyarthritis and pemphigus foliaceus. So just like IMHA and ITP, these 2 conditions can be diagnostic puzzles and oftentimes require multiple therapies. And so I'm just super excited that Dr. Thomason is back to kind of walk us through how to identify and treat these diseases with confidence. Hey, Doc, good to see you again.
Thank you for having me.
Yeah, we're going to jump in, but just like last time, could you, just in case there are audience members that didn't catch part 1, would you just give us a little bio?
Yeah, absolutely. I'm originally from Virginia. I went to undergrad as well as vet school at Virginia Tech. And then through the whole match process, I found my way down to Mississippi State, where I did a couple internships in my residency in small animal internal medicine and stayed on to be a faculty member here. And I've been here for almost 19 years at this point. And my interests are predominantly hematology as well as hemostasis, but I also like a lot of immune-mediated disorders and immunosuppressive therapy.
All right. And in our last episode, we talked a little bit, actually, we opened up the episode talking about a small kind of nomenclature change, which I was totally unaware of, because we're talking a lot about primary versus secondary immune-mediated disease for these cases. And you had said that actually that's now kind of changed a little bit to associated and non-associated, right?
Yeah, it's just frustrating everybody to make name changes. But now I still call everything primary and secondary. Old habits die hard. But primary essentially be non-associative. It's not associated with something else. And then secondaries are going to be associative, or essentially secondary immune-mediated disorders. I still say primary and secondary. It's so much nicer, so much easier. But in case you do start seeing things non-associative, associated, it's primary and secondary.
Perfect. Well, let's start with polyarthritis. What percentage of immune-mediated polyarthritis cases are primary or not associated with anything else? And are there any breed or sex predilections for either the primary or secondary forms?
Yeah, so last episode when we talked IMHA and ITP, they're kind of pretty straightforward. There's a little bit of differences between them, but when we get to immune-mediated polyarthritis, there's a lot of other factors that come into play here. Now, we're not talking about osteoarthritis or the degenerative joint disease. You're going to see that way more often than any of these disorders. Those are very common. These are significantly less common. But even within the polyarthritis sort of framework here, what we've been talking about, we can even separate it even more into essentially erosive polyarthritis and then non-erosive polyarthritis. Now, you guys may have seen commercials or known about rheumatoid arthritis and rheumatoid factor. You may have seen commercials for that. A lot of that's going to be more erosive. Now, that only makes up about 1 to 2% of this type of polyarthritis, not the DJD or the OA or anything like that. That's only going to make up a small portion of it. We don't typically see a lot of erosive polyarthritis. If you do, it's the small breed dogs and it's the small joints, digits, carpus, and tarsi. But since it's so small, I don't think it's worth sitting too much of a conversation about those. We're going to spend most of our time talking about, we could go back to it, so most of our time talking about the non-erosive immune-mediated polyarthritis. Now, within that group, there's a bunch of them. Now, this is where there's going to be primary and secondary. You can get essentially vaccine-associated polyarthritis. You can get drug-induced. Some of us have worked with Shar-Pei's, and you get the Shar-Pei fever. That's going to be an immune-mediated polyarthritis. Even young juvenile Akita can actually get this. And so there's some weird, relatively uncommon disorders that there's usually a cause to. We can call this secondary for intensive purposes to stay consistent. So there's going to be a variety of other ones. But the ones that we're going to talk about in this whole grand scheme thing are the idiopathic ones or the primary. And those will make up a majority of the ones you actually do see. Yeah, you may be near an Akita breeder or a Shar-Pei breeder, and you may see a bunch of them, but for the most part, we don't see a lot of those. And so a majority of them are going to be an idiopathic or primary. Now, within that whole list of non-erosives, it's about 65% are going to be idiopathic. Now, that's what the papers say. Almost all of these that I see are going to be essentially a primary immune-mediated polyarthritis. You can get some reactive ones, so don't be fooled that all of these are going to be. I had a St. Bernard during my residency that had a horrible prostatitis that made that made septic joints, and so you got to go through the process for all of these. But if you can whittle it down to the non-erosive idiopathic or primary ones, a lot of those, most of those are probably going to be your primary. Now, if we stay in that group, a lot of the dogs, the breeds that are going to get it are going to be your larger breed dogs, and a lot of your sporting. So labs, Goldens, some of your shepherds, German shepherds can essentially be in that group as well. And so they tend to be a little bit of a larger breed that tends to get that diagnosis there. And just like last episode, they're going to be middle-aged. If they're super old or super young, I'm going to worry about something else. But middle-aged, larger breed dogs tend to be some of the more common signs associated with it. And they will go to the smaller joints. Maybe not so much the digits as much, but your carpi, your tarsi, as well as your stifles. A lot of times those are going to be the joints that are going to be affected.
I trying to think. I'm not sure I've ever seen a case of primary immune-mediated polyarthritis. Although I did actually have a case in my own Great Dane. She had a really bad urinary tract infection, E. coli urinary tract infection, and I put her on a sulfa drug, which was appropriate, but she developed really severe polyarthritis secondary to that, and I felt terrible. But the good news is it resolved really quickly as soon as I took her off the drug.
So you have seen an immune-mediated one, because that was an immune-mediated, it's a secondary,
yeah,
but it
was
secondary.
Mm-hmm.
It was an immune-mediated polyarthritis. So you have seen one.
Yeah.
But not necessarily the primary ones.
Not the primary ones. The secondary. And it was dramatic.
Yes.
So let's talk
I could
about.
barely walk, probably. Could she walk?
No, she wouldn't get off the couch. She wouldn't. That's how I knew. And then I felt terrible because I was needed to give her dose, and I called her to come over, and she wouldn't get off the couch. And so then I went over to the couch and I pilled her. And about 10 minutes after I pilled her while she was sitting on the couch, I thought, oh my gosh, I bet she's not getting off the couch because of pain and because of that medicine.
Yeah.
And then I felt even worse. But again, she got better and it was okay.
Yes.
So
and you never did it again, did you?
No.
Yep.
No, I did not. Let's talk about clinical signs and presentation. Okay.
Absolutely.
You mentioned in the article, which I found just astonishing, that as much as 25% of dogs don't have effusion or lameness, don't have these typical orthopedic presentations. So what are we looking for with these dogs?
So your dog was the classic. They don't want to get up. They hurt. They may be real stiff-legged when they walk. Some people say they essentially are walking on eggshells when they walk through that. And they just hurt sometimes. And that's the classic way that they present. And then on your physical exam, if you're feeling those joints, they feel puffy. They're not going to like blow up like a balloon. You're not going to see them from across the room. But when you when you essentially feel them and you're extending and flexing them, like you'll see some puffiness there. That's the majority of the case. However, as you mentioned, there are going to be a small subset of these, and about a quarter of them really, where you don't appreciate orthopedic things. Now, the ones that fit into that category do tend to be a little bit more challenging to work up, and they may require more diagnostic tests. But the clues that I have, first, immune-mediated polyarthritis is one of the most common causes of a fever of unknown origin. And so they don't have to be limping. They don't have to be lame. They don't have to have puffy joints. But if they're just kind of like, and they don't feel well, and yet they just constantly have a fever, one of the first places that I'll look at with the joints. Even if they're not puffy, I will still do joint aspirates to see what I have in those joints. So sometimes fever of unknown origins, that's the first place that I'll look for. The other one is just sometimes generalized pain. The times when they're walking fine, they're eating fine. It's just sometimes they just seem like they're always hurting and they're always in pain. And you have joints everywhere. Most of the time we think about the joints in our limbs, but you got joints up here as well. And some of the facets within your spinal cord, they could have the same type of problem. And if they just move their neck a little bit one way versus the other, that could hurt. And so fever and just generalized pain where you can't localize where, a lot of times I'll go to joints with that, and they don't have to have the lameness. They don't have to have the swollen joints for me to think that.
Okay. And actually, yeah, that was going to be my next question, or lead into my next question. So even if we don't have orthopedic signs, your next step is joint sampling. So what is the correct method for preparing and evaluating joint fluid?
Yeah. So we don't do as many joint taps as say the equine folks. The equine folks, they do a lot of joint, and they put biohazard suits on because it's really a serious issue, and they need to be really careful with it. We don't have to be. Now, you should be sterile. Don't get me wrong. You should be sterile, but like we don't have the same complications that the equine folks do with it. And so I do encourage veterinarians, and we even let our students do some of these joint taps as well because they're relatively straightforward and easy to do. I'll usually, because they're ouchy and they're painful, I will usually sedate my patients. I don't usually have to go all the way full general anesthesia. Usually I'm fine with a little bit of sedation. But I will get radiographs beforehand just to make sure that I have the non-erosive form instead of the erosive form. But once they're sedated and I have radiographs, just clip up the fur around your joints. Like I said, I will usually do my carpi, tarsi, and the stifles. I think the carpi and the stifles are the easiest. I think the stifle is the easiest, but carpi is second on that. And then any affected joint. Let's say maybe the elbow is really inflamed or really puffy, get that one. But I'll usually do both carpi, both stifle, and maybe a tarsus, depending on what I feel. So sedate them, clip up in those areas. You don't have to do all over. Just like do a little square over top of that joint there. And before I do a surgical scrub on it, I will flex and extend the joint pretty well. And you should be able to feel as you flex and extend that joint, you should feel little pockets that may open up a little bit. And sometimes you may just have to essentially poke around a little bit until you get that. And you get an idea of exactly where you're going to be in. Now, if you're doing on the stifle, you want to go medial lateral to the patellar tendon there. But even with that, as you bend that, you're going to feel little squishy areas where you're going to want to go into. But if you went right smack dab in the middle, you're going to hit that patellar tendon, and it's going to be firmer there. So you go off to the side, essentially find those little squishy areas, and that's where you're going to want to go. And so after you figure out exactly where you want to go, do your surgical prep. I will wear gloves, and you just need to take I usually get about a 3 cc syringe, and then a 22 gauge needle. You don't need to get a 20 or 18. You don't need to get a massive gauge needle in there. But I usually take about a 22 gauge needle, and I will essentially go into that squishy spot. It will hopefully be within that joint cavity. Now, you may miss, but don't just take your needle out altogether. Try and walk it off a little bit in one direction versus the other. And you'll feel it as you essentially walk to one area. I'm on bone, and I'm not. And you'll sort of sink into that. And once you sort of sink into that little pocket, go ahead and then pull back on your plunger. Now, you're not going to get a lot of fluid normally. However, if you have a really affected joint, you could get actually quite a bit of fluid in there. But even if you don't get fluid, it doesn't mean that it can't be. Now, probably everyone remembers the string test. If you put a little bit of normal synovial fluid within there, you should see pull it apart, you get the little string there. If you do that and you don't see a string, that's going to probably be diseased. Now, I don't usually just waste my synovial fluid on my fingers because that's valuable stuff. You may only get a couple drops. But if you put a drop onto a microscope slide and you pull your needle up, you actually get a little bit of a string with that. So they can give you a little bit of a tell there. If you put that little drop on there and you don't get a string, well, you may have some disease, synovial fluid there. Now, if you have buckets load of it, sure, do the string test, but you're not going to have buckets of it. And then you can if you only get a drop or two, you can make a slide for cytology. If you get a bunch, you can get some fluid analysis on there as well. But yeah, that's what I'll do is I'll do one. Usually what I'll do is I'll do one, and I'll essentially show the student and walk them through it, and I'll let them do it, because this is a procedure that can be done in general practice all the time, and it just takes a little bit of sedation, some needles and some syringes and some microscope slides, and if you get enough, I would actually send some out for culture as well. But it can be done quite easily and quite quickly too with it. Now, for the first couple times, you may want to do it, especially for, say, the tarsus. The carpi, as I mentioned, carpi and stifle are pretty easy. You may want to get some landmarks out there to make sure you're going to hit the joint, but still flex and extend that joint and essentially figure out exactly where it's going to open up for you to be able to get your needle into it. Now, once you have your sample, like I said earlier, if you just get a drop, just put it on a microscope slide and essentially make a sample of that. But if you get a bunch of fluid, go ahead and make a couple of slides, but then save that fluid, one for a fluid analysis, or I guess two fluid analysis, but also save some for culture. Because one of the things that we don't know about quite yet as we go through this process is that going to be septic? And you could potentially get a positive culture on your synovial fluid analysis there. So cytology, fluid analysis, and culture, if you have enough in that regards there. So, but they are relatively straightforward. If you do a couple of them, you're going to get good at them. And I do encourage a lot of veterinarians to be able to do that, because that's something that can be done and can really help out some of these patients.
Why do you think it's important to sample the multiple joints?
Yeah.
And how many are you averaging, or how many are you shooting for on a particular patient?
So if we're going to go to be the official polyarthritis, you need to have documentation of disease in 5 joints. Now, that's a lot of joints. And I don't always do all joints that I can get my hands on. Like I said, I'll do the ones that I can get easy access to, and the ones that are puffy or inflamed. And I may get 4 joints out there as well. But and if I happen to get 5 or 6 because I need to get 5 or 6 because they're all kind of bad, but I don't say, oh, well, I only got 4, but I have to get that 5th to make this a polyarthritis. If I get 4 joints and maybe both carpi and both stifles, or maybe both carpi and both tarsi, to me that's enough. It's obviously documentable in multiple joints. It may not meet the magic 5, but you know for sure that you're going to have it in multiple joints that are going to be affected.
And then once we have our diagnosis and we start talking about treatment, we had talked actually the last episode about the different areas where, ticks and things are endemic. So do you recommend putting all these dogs on a trial of doxy before you start immunosuppressive therapy, especially in tick endemic areas of the country?
Yeah, and you hit the nail on the head on that one. Is if you are in a geographic area that you have some of these infectious agents, particularly tick-borne, and if it's safe enough to be able to do for that patient, I do think a trial of doxycycline would be totally appropriate. Especially if you're in the Northeast, you get a lot of Lyme disease up there, and you can get a lot of these as well. So if the patient is stable and it's doing well, and you have time, I think in those endemic areas, I don't think it's anything wrong to do a course of doxycycline. Now, if you're not in an area that has a lot of endemic tick-borne diseases, then I'll say, I don't know, maybe Vegas. Then you may not necessarily want to add that on, and you can actually go to additional therapy after that. But if you're in an endemic area and the patient is stable enough and healthy enough to be able to go through a course of therapy, I don't have a problem with it. But this is where it essentially tugs at your heartstrings a little bit, because these patients hurt. And if it's truly essentially a primary immune-mediated polyarthritis, a little bit of steroids goes a long way with these patients. And sometimes it hurts you a little bit to say, well, I have an option. I have a treatment that may work really quickly and relieve all your pain, but let's hold off on that till we get a month worth of doxycycline. And so If they can wait a little while, I don't necessarily have a problem with it. But if they just can't wait for a full trial course with the doxycycline, maybe start the doxy, and then if that doesn't work relatively quickly, then you add the steroids on top of that. So a lot of times when I talk about immunosuppressive therapy versus not immunosuppressive therapy, I say go with the least risky first. In this case, say doxycycline. But if you just can't, do combined therapy where you do immunosuppressive therapy and doxy at the same time. So yeah, I think it would totally be appropriate if you have time to be able to do a trial course of doxycycline, and yet the patient still can handle it all.
And then, like you said, these patients are really, really painful.
Yeah.
It sounds like the steroids work really quickly to help handle that, but do you also include other analgesics? What analgesics are safe to use alongside corticosteroids? Obviously, we're not going to be throwing NSAIDs at these animals if they have, high doses of bread on board.
So for the primary ITP or immune-mediated polyarthritis, you're absolutely correct. You don't want to combine steroids and NSAIDs. Now, if we back over to the non-primary ones where it's essentially vaccine-associated or drug-associated, where they just need some pain meds, yeah, NSAIDs are fine for those. But if this is the primary immune-mediated polyarthritis, yeah, stay away from the steroids. Sorry, stay away from the NSAIDs. Any other pain medication that you think would be appropriate? Gabapentin, some people use Tylenol, Tylenol 4. Those would be appropriate. Now, we've had some of these patients that we waited and waited and waited to give steroids because we were worried about septic or for some other reasons. And like we would even go on strong opioids. We go like fentanyl to try and maintain their pain. Sometimes it's not enough. Sometimes it's the steroids actually does wonders. And steroids can work quite quickly. And so if these patients are just so unbelievably painful and you can't get control for with whatever non-NSAID analgesia that you have, sometimes steroids are really the only thing that are going to get you any type of improvement with that. So okay. It hurts your feelings a little bit just to watch them be so painful.
It is very, very hard. Again, back to my poor Dane that wouldn't come off the couch. And that dog would do anything for me. And so sometimes these dogs are kind of on long-term immunosuppressants, correct? How are you monitoring these patients, that are on really, months and months and months of therapy? And what are you looking for a therapeutic response in those patients?
So last episode when we talked about IMHA and ITPs, we had it kind of easy because if they were anemic, you checked a PCV. If they're thrombocytopenic, you checked a platelet count. Like that was easy. It's easy enough to do. This is a little bit of a different story, is because what do we look for to essentially say my therapy is responding? Now, the obvious thing is going to be, do they walk better? Are they no longer in pain? And so, okay, we're good there. That a lot of time is pretty easy to tell. But the question is, when do we start taking them off steroids? Like, how have they done well enough to be able to get off drugs? The ideal thing is what you would do is you would sedate them again, tap all joints again, and see what kind of response they're getting. But owners don't want that. It's one thing to tell them, hey, we need to sedate and tap joints when their animal was sick. But now that they're better, you want to do the exact same thing. Owners aren't going to go for that. So the ideal option would be, let's retap the joints. But we're not going to do that in most cases unless there's some problems. And so it would be really nice to have a more objective assessment of, are they responding? And so you can actually use C-reactive protein as a guide there. It's actually a pretty good guide to say, hey, there's some improvement there or there's not. Now, it's a non-specific indicator of inflammation. So you could have a secondary or non-associated or completely different cause of inflammation that caused your C-reactive protein to go high. But as long as you just have one problem, the immune-mediated polyarthritis, your C-reactive protein could be your clue. And if it got better, so the C-reactive protein dropped and got better, you could use that as your surrogate marker of improving. And so clinical signs and C-reactive protein a lot of times is going to be what I use to say, hey, this patient is actually responding, this patient's actually doing pretty well.
Yeah, that's great. Yeah. Definitely.
Now, length of therapy, sometimes they will respond beautifully. And sometimes within 24 hours, you can see a stark difference. but sometimes they take a really long time, and it can be very frustrating because the owners are seeing them too. They're essentially just not walking well. The owners can see this. When we talked about IMHA and ITPs, they can't necessarily see the red cells or see the platelets, but they can see their dog being uncomfortable. So owners can get essentially tired of this as well, just seeing their dog sort of recover a little bit. If they recover, great, wonderful, they'll do very well. But some of the ones you may have to go potentially months on immunosuppressive therapy in order to get some resolution of these. And some of these still won't respond, unfortunately.
Yeah. That's a good tip though about the C-reactive protein, because
Yeah.
it is one that I forget about.
Yeah.
Wasn't used at all, when I first
Yeah.
started practicing, but
Yeah.
pretty readily available now,
Yeah.
at several commercial diagnostic labs. So that's
Yeah.
nice.
Yeah. I'm saying that I forget about it too. A lot of patients have multiple problems of inflammation, like it's non-specific.
Uh-huh.
But for this
Yep.
case, if that's really the only known problem, it's a good little marker of a response to therapy.
Perfect. All right, we'll take a little break and then we'll jump back and we'll talk about our last condition, which is pemphigus.
Get the fast results your canine patients deserve. Think fast. Think Apoquel, oclacitinib tablet for allergic itch relief starting in as little as 4 hours. Visit apoquel.com for full prescribing information and to learn more. May cause worsening of existing parasitic skin infestations, serious infections, or pre-existing cancers. New neoplasias have been observed. Do not use in dogs under 12 months of age with serious infections or in breeding, pregnant, or lactating dogs. Think fast. Think Apoquel.
All right, let's talk about pemphigus. Pemphigus foliaceus, I think, is reported to be like the most common or one of the most common autoimmune-mediated skin diseases in dogs. This is one that I have a question about, back to our primary and secondary. Yeah. Is pemphigus always considered a primary immune-mediated disease, or are there potential triggers or precipitating factors that might result in like a secondary pemphigus?
Yeah, so this one is probably going to be different than some of the other ones that we've talked about in this episode and the previous one. And most of these are probably going to be primary. And it's honestly usually within a lot of specific breeds, particularly the Akitas and Chow Chows. Now they're somewhat related in that regards, but and that may be why you see them in those breeds. But yeah, although any dog and cat can actually get it, those are the breeds that are going to be more common. And so there's probably something within their DNA, that essentially sets off those autoantibodies to be able to say, hey, this is going to be a primary immune-mediated process. Now, they've looked at things to say, is there a cause? Is there an underlying thing that essentially sets this off? Some of these dogs will have concurrent allergies, if that's going to be whatever that may be, whatever the allergy may be. Drugs could do it as well. So anything that may essentially be a drug allergy, so a lot of your antibiotics, some of your cephalosporins, some of your penicillins, some of those may actually essentially set this off. But for the most part, most of your pemphigus foliaceus dogs, it's probably going to be primary, and it's probably going to be some of the more breeds that are more commonly associated with it.
I think a while back, it's been a long time now, but there was actually like a topical amitraz product that I remember that was causing like a localized pemphigus.
Yes. Yeah. And so when I was talking to a dermatologist, she said that exact same thing. She said, she actually said, don't bring it up because it's not on the market anymore.
No, it's not.
But
I remember it because I'm that old.
Yes. But she said, yes, there was a product that, an Amitraz product that led to essentially pemphigus foliaceus, and that did cause a lot of problems, but it's no longer available. Yes. But there are some drugs that can essentially lead to it.
Sure. Yeah. You talked already about, breed and sex predilections. What about typical age of onset? Do we see a particular age of onset, or can we see this in young and old alike?
Yeah. Yeah, so I'm going to sound like a broken record here. It's going to be middle-aged dogs. Somewhere between the 4 to 6 range is usually where you may see it. Now, if you start seeing some lesions, once again, older age or really young, could be something else. But yeah, so the middle age group is kind of going to be where you see most of these patients that will pop up with it.
And this is something that I used to think, when you looked on cytology, people talk about these acantholytic cells,
Yeah.
and I used to think that that was actually like pathognomonic for pemphigus, and I've actually found
Uh,
out that's not true. Other
yeah.
disease processes can cause,
Yeah.
the acantholysis with the cells. But
Uh,
can you talk a little bit about the appearance of the cells and why they get
yeah.
that
Yeah.
shape?
So a lot of it goes back to why the disease happens anyways. And so you have your epithelial cells that are essentially stuck together beside each other, and they have connections between cells, but they also have connections to the basement membrane. Well, when there are antibodies or autoantibodies that get directed, essentially is directed at those connections between the two cells. And so they lose their ability to connect, and they essentially may flake off a little bit in a way. They don't actually flake off. I'm being a little liberal with my words here, but essentially will come apart. And so you'll start getting some blisters associated with it as you start losing some of those connections with those cells. And they will be round sort of epithelial cells. A lot of times they'll be in clusters as well. And so it's not going to be diffuse everywhere, but you'll get a cluster here and a cluster here and a cluster here. And they're going to be substantially larger than neutrophils. And so you'll see a big old cell, but right beside you'll see a much smaller neutrophil. And occasionally you'll see some eosinophils in there as well. But what you're seeing is you're seeing some of those cells that essentially just are breaking apart and coming away from each other. And you're right, it's not pathognomonic for pemphigus foliaceus, but but it's pretty common. Some really bad pyodermas, some of the some of the ringworm stuff can actually essentially
Mhm.
cause that as well. It has to be pretty bad though for both of those to happen. But yeah, as those cells sort of come apart there, you'll start seeing them in some of those pustules. And eventually what's going to happen is those pustules break apart. You start getting some little craters and you get some crust associated with it. But yeah, it's not pathognomonic, but it's pretty close.
Yep. They always, were always described to me as that fried egg appearance. And so,
Yes.
yeah, anytime
Yep.
I see them
Yep.
now, that's all I think of.
Yes.
It goes back to those public service announcements that were like, this is your brain on drugs.
Oh,
And I'm like,
yes,
and this
yes,
is your skin on pemphigus. That's what it always,
yes.
that's what I always thought
I've
of.
forgotten about those commercials.
All right, let's talk treatment.
Yeah.
Is it going to be steroids?
Shocker.
What
It's gonna be steroids.
So what immunosuppressive
Yeah.
medications are we grabbing first?
So it's going to be steroids. Now, there are going to be a whole host of secondary immunosuppressive agents. Now, we haven't talked a lot about the second immunosuppressive agents. We talked a little bit about cyclosporin, but if steroids are enough, great. Why use two drugs when one drug would work? But a lot of times you may need to add on a second immunosuppressive agent to try and get control of this. Now, if you go back and look historically, there's been a lot of work with azathioprine in pemphigus foliaceus. Now, that's fine. I use azathioprine quite a bit, mostly for my IMHAs and ITPs, but there's nothing wrong with it. But it does come with its side effect profile. And so one of those particularly that causes probably the most amount of problem is going to be is an hepatotoxic drug. And so you can have your ALT and some of your liver values that essentially increase with it. It can cause some myelosuppression and pancreatitis and a few other things. But there were a lot of those dogs that were getting treated with azathioprine that were having some side effects that were a little bit less desirable. And now not only you're dealing with a skin disease, now you're dealing with a liver thing. And so there are fewer people, I think, that will use azathioprine compared to some other immunosuppressive agents, secondary immunosuppressive agents that we've used. Now, one of the drugs that does get used more often, azathioprine may work for a lot of it as a secondary immunosuppressive agent, but has the side effects. Well, could we get that same benefit with fewer side effects? And well, that's where mycophenolate mofetil comes into play. And so you can certainly consider mycophenolate out there as well. Now, I like cyclosporin. We use it quite a bit, not only clinically, but also for research. But I think all of those drugs would be an option. Leflutamide is another one that is actually one of the drugs I use for anemia polyarthritis, but that is another one. However, that doesn't typically get used as much for skin stuff as, say, cyclosporin or mycophenolate or azathioprine. But from an immunosuppressive point of view, it's going to be steroids. If it don't get the response that you want, probably one of those other immunosuppressive agents.
I do find that a lot of times with this disease, there are secondary pyodermas, so
Yeah.
what role do oral and topical antimicrobials play when we're managing pemphigus and
Yeah.
diagnosing? Because it can confound our skin biopsy.
Yeah, absolutely. You can see a whole bunch of bacteria and you're like, oh my gosh, I got a bad deep pyoderma or something like that. So it can absolutely influence a diagnosis in that regards. They do tend to respond better when they're on steroids, or when they're, well, yes, on steroids, but with antibiotics as well. In things like your cephalosporins, your clindamycin, and maybe even as much as clavamox would usually be an appropriate antibiotic to add on top of that. I don't necessarily use a lot of topical antibiotics, although I guess that could be an option there. The thing is, you may have to cover the patient a lot with a lot of topical antibiotics. If it's just confined to the nose or maybe essentially around the eyes, that's one thing. But if you start getting it on the nose and the eyes, on your paw pads, and a lot of them will essentially go generalized, you're going to essentially be painting the dog with topical antimicrobials. And so sometimes it just may be a little bit easier to just give them the systemic, the oral ones, and have it address that. But yeah, I think a course of antibiotics would certainly be appropriate for a lot of these patients.
Are there particularly common complications that arise when you're treating pemphigus? This is another one that I know we can treat for a long time. It can take a long time to achieve remission, and then we can sometimes see flares. So how are we monitoring these patients, and what are we doing to mitigate flares?
Yeah, it can be frustrating. You're exactly right. I mean, it could take months to essentially get resolutions, and this is another one where the owners are going to see it, and it's going to be a constant reminder that they're not getting better. So it can certainly be frustrating. Now, compared to immune-mediated polyarthritis, it actually works out nice because you just look at the dog and you say, hey, they're better, or they're not better. You don't have to have all these fancy diagnostic tests that we run. You can just look at the dog and essentially see some bit of a response to it. But I would also essentially make sure you check other places. It may start on the face, but check paw pads, check nail beds, and then it can go generalized as well. And so make sure your owners are also doing some good surveillance to see if any more lesions are popping up. But the nice thing about this one, out of all the immune-mediated disorders that we've talked about, you can see the response, and you know if things are getting better or getting worse.
And then when we're looking at tapering off these medications, I'm really interested in just how do you approach that, especially if we're on multiple drugs? Do you try to get down to one drug first? Do you taper back and forth? I'm going to taper my pred this week and I'm going to taper my mycophenolate next week. How do you approach that?
So this can actually be applied not only to the pemphigus that we're talking about, but all the other ones from last episode as well as this episode. I kind of keep the same process no matter what my immune-mediated disorder is. I go whatever immunosuppressive agents I'm on, I go until I get a response. Some people for the IMHAs that we talked last time may wait till they get to a PCV of 30, but I wait till everything's normal. Platelet count, red cells, joints, in this case skin, whatever it may be, I tend to wait till they're back to normal or back to where they should be. And then I will slowly start weaning off drugs. And I tend to wean the drugs a little bit slower than some because I've had some where if they've relapsed, sometimes it's harder to get them back under control. So I tend to take a little bit more of a cautious approach, and I will wean slower. I wait till they're normal or they're in a good place, and then I start weaning one drug at a time. Now, which drug is that going to be? It's the drug that's causing the most amount of problems. And usually it's going to be the steroids. The steroids work wonders, but they do come with their whole host of side effects. And so I usually end up weaning down my steroids first. And I do about a 25% dose reduction with my steroids. Now, I do steroids once a day. I don't do it twice a day. Really no shown evidence that twice a day immunosuppressive doses of pred is any more effective than once a day doses of immunosuppressive therapy. So I'll do once a day. I usually give it in the morning. And then I do 25% dose reduction. So I start at 2 mg per kg, I down to 1.5, 1, and then a half, and then essentially wean that off. But I do that every 2 weeks. So once they're good at 2 mg per kg worth of your pred, I will then, and for larger breed dogs, I do reduce my dose just due to the side effects. I will then wait 2 weeks, and I'll look at their skin, or I'll look at their red cells or their platelets, and then if everything is still good, then I was at 2, 1.5, down to 1. I'll wait 2 weeks and do it at a half a mg per kg. And then I try and get off that first drug altogether. And then I do the same thing with the second immunosuppressive agent. Let's say it's cyclosporin. I will use cyclosporin at whatever dose he or she's been on. And then I go down a quarter, 25%, go down another quarter, and until I'm off. And so it may take months once that you have gotten back to where you should be. But like I said, I've had so many of these dogs where they got weaned off really quickly, and it's just so much harder to get them back in. And sometimes owners lose enthusiasm and interest at that point. They're like, we tried so hard, we just got them into remission or got them back good, and now we got to go through it again. Sometimes you may lose the owners in that regard. So I tend to, if I got them, I tend to go a little bit slower, and I do one drug at a time, roughly every 2 to 3 weeks, and do about a 25% dose reduction each time.
And then if you start to see a flare, you just go back to the dose that they were controlled at?
I guess it depends on how far along you are. If you just made a very subtle drop and then they flare back up, I'll essentially go up there. But if I was almost off all drugs altogether and it's just slowly creeping back, and this is for all the immune-mediated disorders, I may not go back full bore with both drugs. I may just choose one drug and essentially go back to a higher dose with that one. Now, the side effects essentially have to play a role in this as well. If that one drug that really worked with steroids and the side effects are horrible, I may question this. Maybe I only go up to 1.5 mg per kg, or maybe 1 mg per kg, or once again for larger dogs on a meter squared basis. So I will certainly go up my dose, but depending on how that patient handled that drug the last time and how severe it may be, then yeah, I will certainly bump up the dose. But how high? There's a little bit of art to practice here.
Back to the art of practice. I was just going to say.
Yeah.
All right. Yeah. Oh, Dr. Thomason, this has been so wonderful. I just have really enjoyed it. That's the end of all my questions, except if you want to play Would You Rather again.
Absolutely.
All right, here we go. Would you rather stop teaching and continue to practice, or continue practicing but no longer teach?
Oh. You're going to take my vet card away from this. I would like to teach.
Yeah.
15 years ago would have been a different story. I just wanted to be in the clinic. I enjoy the teaching aspect of this more at this point in my career. Now, I couldn't stand in a lecture hall all day, every day, and just lecture. And so the teaching that I like to do is with the patient. And it's like, oh, you see that patient? Okay, what do you think about that? And then we can dive into it a little bit that way. But yeah, you may take my vet card away from me, but I kind of like the teaching a little bit more at this point in my career. 15 years ago, I would have had a different answer for that, but the students make it fun. The students are fun, and sometimes they'll test you as well. They come up with some good off the wall stuff that I never thought of before.
Yep. Perfect. Okay. Would you rather do your own taxes or complete an international health certificate?
I already do my own taxes, so yes, that one. I don't want to do those international things. We fortunately have some faculty here that will do it, and I just look at it and I'm like, I'm glad you were here, so I don't have to do it.
All right. Would you rather work up a mystery case with 40 pages of handwritten notes from the owner detailing every moment of their dog's day, or no history at all because the person who brought the pet in is not the owner?
Yeah. I would much rather have the 40 pages. It takes a while to go through it, but at least I have something to go on. And usually by the time patients get here anyways, they've already seen multiple vets, or sometimes just one. They've done a whole bunch. And so, I would much rather have that. Get me something to work with here. Yeah, I would much rather take the 40 pages.
Comb through all of that data.
Yeah.
Okay. Final question.
Yeah.
If you were the inspiration for a veterinary superhero, would you be in the Marvel universe or the DC universe?
Oh. I guess Marvel, solely because I don't know much about the DC universe.
Okay. All right. Marvel's in a little slump right now, so I think they need a veterinary superhero.
We can build it up again. Yeah, it's fun to build something instead of essentially being at the top.
Okay. Oh, that was it. Thank you so much, everybody at home. This concludes our 2-part series on primary immune-mediated diseases in dogs, and I hope you enjoyed it as much as I did. We hope you'll come back and join us for more conversations behind the content.
I would love to. Thank you for having me. This has been fantastic. I really appreciate it.
Thank you for listening to Clinicians Brief, the podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.